I'm Dr. Maureen Clement, Medical Lead for the Interior Health Diabetes Strategy. I will be reviewing the pre-printed orders for insulin pump management in emergency and acute care. This PowerPoint will review the purpose of the pre-printed orders, review the accompanying documents such as the patient agreement, questionnaire, and insulin pump log. I will talk about when it is necessary to temporarily stop the insulin pump, special considerations such as obstetrical and surgical patients, and how and when to transfer patients from the insulin pump to subcutaneous injection. Many patients with diabetes, largely type 1, are capable of managing at home on their insulin pump. The purpose of these pre-printed orders is to allow those patients to continue to self-manage in hospital if they are found to be competent and able to continue. It is also important to discontinue the use of insulin pumps in patients who have become unable to self-manage due to a change in their status. The most responsible physician, with the assistance of the nurse, will assess all patients, adults and children, wearing an insulin pump for their ability to manage the insulin pumps in hospital. This applies to the emergency department or acute care. Patients will be reassessed on transitioning to a new patient care unit due to changes in the patient status, such as leaving or entering the ICU, or leaving or entering the surgical floor. An insulin pump is a small device about the size of a pager, which contains rapid insulin only, that meters out small amounts of insulin to mimic a basal rate. The patient then tells the pump how many carbs, how much exercise, and what their present glucose is, and along with the pump helps calculate small boluses of insulin. The pumps are quite sophisticated in that they can alarm, for instance, when insulin is not delivered. Controls can be set so that large amounts of insulin are not delivered accidentally. 2 out of the 3 commonly used pumps use a reservoir within the pump filled only with rapid-acting insulin. The insulin is delivered through thin tubing to a subcutaneous site called a set. This set is generally replaced in the subcutaneous tissues via a small cannula every 2 to 4 days. If for some reason the pump needs to be temporarily discontinued, the tubing may be discontinued from the subcutaneous set, or if the pump needs to be removed, the entire set can be lifted off the skin. There is another type of pump called a patch pump, where the insulin and the set are one. This entire small device is replaced every 2 to 3 days. If this needs to be removed, the entire mechanism is lifted off the skin. The only patch pump available at the moment in Canada is the Omnipod. When insulin needs to be delivered to set basal rates as well as delivering boluses, the patient uses a small handheld device. The insulin pump pre-printed order is a 2-page document. On the back of the first page is a decision support tool that will explain how to change a patient from an insulin pump to sub-Q insulin using the total daily dose. These instructions are very similar to those found on the pre-printed insulin order for subcutaneous insulin. On the back of page 2 is a decision support and guideline for oral treatment for hypoglycemia in children, as there is no hypoglycemia protocol in place for children. There are 2 forms that must be presented to the patient or to the caregiver. These are to be completed. The patient or caregiver questionnaire will outline whether the patient or caregiver feels comfortable and confident to manage the insulin pump. They will agree, if they are the caregiver, to stay with the patient while in hospital. They will be asked which type of insulin is used in the pump and to give typical total daily doses, list basal rates, insulin sensitivity, and carb ratios. This is all information that anyone who manages their own pump should be able to give easily. They should be familiar with these forms through the Diabetes Education Center. The second form, the patient caregiver agreement, is signed, and the patient acknowledges that they will complete the insulin pump log. They will report any problems with the pump to the hospital staff and physician, and they will supply all their own insulin pump requirements during their hospital stay, such as insulin reservoirs, tubing, and sets. The hospital will supply rapid-acting insulin aspart for the pump. The patient will also sign that they understand understand that the pump may be temporarily disconnected or discontinued based on an impairment in their judgment or level of consciousness, or when they need certain procedures such as an MRI, PET scan, mammography, or CT scan, or for any other reason deemed necessary by the medical staff. The third accompanying document is the patient caregiver insulin pump log. This is where the patient can record such things as blood glucose, amounts of carbohydrate, meal and correction boluses, basal rates, when they have changed an infusion set, when the pump has been removed or reconnected, and any pump setting changes. This is to help patient and caregiver self-management, as well as to inform the medical staff of diabetes management. The required information from the patient is a minimum of 4 blood sugars per 24 hours, to record all hypoglycemia or blood sugars greater than 15. As well, if they make any changes to the pump settings, including basal rates or sensitivity or carbohydrate ratio, these should be recorded on the log. Now, the actual pre-printed order for insulin pump management. First of all, a new PPO must be completed for each assessment. That is, when they first present to the emergency department or the acute care site, or if they are changed because of medical reasons to a different area of the hospital, such as to or from the ICU or to or from the surgical floor. This pre-printed order is set up the same as all other pre-printed orders throughout IH. Number 3 is the section to assess the capacity and agreement to self-manage the insulin pump. Patients are first assessed to be sure they are alert and oriented with no altered state of consciousness or cognitive status, including no medication-related impairment. The patient complete both the patient caregiver questionnaire and agreement. Together with these documents, the most responsible physician will assess for contraindications, such as any sign of mental illness that would interfere with the self-management of diabetes, such as the patient is suicidal, any critical illness such as sepsis or trauma, persistent unexplained hyperglycemia, diabetic ketoacidosis, persistent unexplained hypoglycemia, that is 2 or more blood sugars less than 4 despite medical consultation and treatment review, or any refusal to participate in self-care or sign the patient caregiver agreement, or finally, if there is any questionable patient caregiver self-management competency issues. Once the capacity and agreement to self-manage the insulin pump has been assessed, the MRP will make the decision to either tick box option 1 to discontinue the insulin pump or option 2 to continue with self-management. If box number 1 is ticked, it is important to put the major reason for discontinuation of the insulin pump. The reason for this is this may change over time. At that point, the physician will write orders for subcutaneous insulin using the standard insulin subcutaneous order adult eating or NPO form. On the back of this present pre-printed order is a decision support that helps convert patients from insulin pump therapy to subcutaneous multiple dose injection, and it is essentially the same as the pre-printed insulin orders using total daily dose. If the patient is found to be competent, capable, and agrees to self-manage their insulin pump in hospital, option 2 is chosen. The type of rapid insulin used in the pump prior to admission is ticked. The hospital pharmacy, however, will supply rapid-acting insulin aspart in vials as required. It is the patient's responsibility to maintain and document the insulin pump management, including refilling the reservoirs with rapid-acting insulin. On occasion, the patient may require pre-filled insulin pen with aspart to bolus. This is sometimes necessary if they are on very large total doses of insulin, such as towards the end of pregnancy, or if there is a set failure temporarily, they may need to bolus rapid insulin from a pre-filled pen. Section 5 pertains to blood glucose monitoring. The nurse is to measure blood glucose before meals and at HS. The doctor can indicate whether they want additional blood glucose is done. Also, an acceptable range is entered. The physician will be notified if blood glucose levels are out of an acceptable range more than 30% of the time. For hypoglycemia, adults, The hypoglycemia protocol is followed automatically. For pediatricians, they need to indicate at what level they would like to be notified and what treatment for hypoglycemia. On the back of page 2 is a decision support for oral treatment for hypoglycemia in children and adolescents. If the patient wishes to use their own blood glucose meter, the lab requires that they do a meter to lab check, which must be within 20%. Special considerations. For the surgical patient who is having elective surgery, they would complete the forms and have a discussion at the standard face-to-face pre-surgical screening. At that time, a decision can be made by the anesthetist, the patient, depending on the length of the surgery, whether they would use their insulin pump during the surgery. For non-elective surgery, the anesthetist will order the continuation or discontinuation of the insulin pump, again, based on blood glucose control, length of surgery. Postoperatively, insulin orders will be completed by the MRP. In terms of obstetrical intrapartum care, please refer to Diabetes Type 1 Management of Intrapartum Care. Many patients who are Type 1 who are delivering are now on insulin pumps, and insulin pump protocols have been embedded into the Type 1 Management of Intrapartum Care, and those pre-printed orders will be followed in lieu of these ones, although the patients will sign the forms such as the caregiver agreement and caregiver questionnaire. Once again, these will be presented to the patient through the diabetes center prior to their arrival at the hospital. On occasion, the insulin pump may need to temporarily be disconnected. The patient can generally do this at the site or the set for those pumps using tubing. For those with the patch pump, such as the Omnipod, they would need to actually remove the pod. This can be done safely for up to an hour. If the pump must be discontinued for more than an hour, the patient may require small boluses of rapid insulin that they would be able to calculate to replace their basal rate. Or for longer discontinuations, basal insulin would need to be started. Basal insulin takes about 2 hours to cover their basal needs, and pumps may need to be continued for a bit of time until the subcutaneous basal is effective. Once again, a decision support is available on the back of page 1 of the pre-printed orders that helps to inform physicians how to write orders transferring patients from the pump to subcutaneous insulin. It is based on a total dose of insulin, half of which is basal. Often this basal is then again divided in half and given Q12 so that when patients transfer again onto the pump, they only have half of their basal insulin for the 12 hours active, so that the patients, when they resume pump therapy, do not have to use a temporary basal until the subcutaneous basal has finished.